So this is Reg Tan, and I'm going to demonstrate a lensectomy in a subluxation lens with a transsclerally sutured CTR. Now here, we are confronted with a 17-year-old with a bilateral supranasal crystalline lens dislocation. Now I'm going to show a technique my mentor, Dr. J. Vicencio, taught me how to do. We begin by making a peritomy opposite the area of the lens subluxation and within the same axis of the zonular compromise. We then make two paracentesis ports at the same area of the peritomy. After injecting trypambuline viscoelastic, we proceeded with our main corneal incision using a 2.75mm keratome blade. We see that the patient's cornea is really soft, probably due to the patient's young age. So a cystotome needle was used to puncture the anterior capsule. The goal is to do the capsulorhexis as supranasal as possible. Through the paracentesis ports done earlier, we use an iris hook to hold the anterior capsular rim and pull the bag centrally. With this, we can further enlarge our rhexis and place another iris hook. With two iris hooks pulling the bag intranasally, we managed to complete our continuous curvilinear capsulorhexis. Here, a 9-0 proline suture was threaded into a gauge 30 needle, and using the gauge 30 needle, we pierced the sclera 1.5mm from the limbus and redirected the needle to the AC. So the proline suture was grasped from the needle and brought out of the main corneal incision, and this was tied to one of the fixation eyelets of a Cionni-modified CTR. In inserting a Cionni-modified CTR, we had to be sure that the leading eyelet goes inside the bag. So here, you see that we are carefully threading the CTR into the bag. We also made use of a lens rotator to assist us in placing the other eyelet inside. After removing the iris hooks supporting our capsule, we proceeded in securing the proline to the sclera using a Z-suture technique. After doing the first intrascleral pass, we noticed that the lens bag complex centers upon pulling on the suture. We continued to make 4 more 2 to 3mm parallel intrascleral passes. Then we cut the suture at the base and leave it knotless. Now the Cionni ring holding the capsular bag is secured in the center. We proceeded in doing hydrodissection and hydrodelineation and INA of the lens material. We noticed that it can be quite difficult to remove the cortex after being sandwiched in between the CTR and the bag. After aspiration of the remaining cortical material, we injected viscoelastic and implanted a foldable acrylic IOL inside the bag. After some rotation, we noticed that the IOL optic centers very well. We injected carbachol into the AC to constrict the pupil and remove the remaining gel. The conjunctival was closed using nylon 10-0. 1 day post-op, the IOL was centered inside the bag and the patient was happy.